Hello again. Now we're going to go on with bleeding. Bleeding is a part of first aid that is very important. And the reason it's important is because the human body does not have an unlimited supply of blood. In actual fact, the human body holds about 8% of its body mass as blood volume. We as first aiders need to control the loss of blood to try and reduce the chances of the condition becoming worse. Sometimes it's not always possible to stop the bleeding because of the severity of the injury. So if as first aiders we have a goal of trying to slow the loss of blood, which is probably more achievable from a 1-day trained or 2-day trained first aider, opposed to stopping bleeding, we'll definitely achieve the goal that we set. We have adopted a very simple principle to treat a bleeding injury, and if we can adopt this principle, it makes your job that much easier. If we think of the colour of blood, the colour of blood is red. The word red is made up of 3 letters, R, E and D. Those 3 letters remind us of what we need to do to treat a bleeding injury. The R standing for rest. By getting a casualty to rest who is suffering a bleeding injury, we will lower their heart rate, in turn reduce the amount of blood that has been lost. So it's very important to get our casualty to rest as soon as possible after you've identified the bleeding injury. We then move on to the E phase of the treatment. The E stands for elevate. If we can elevate the injured part, in this case the casualty has a bleeding injury to the right forearm. If we can elevate the injured part above the level of the heart, this will make it harder for the blood to be pumped into the injury, in turn reduce the amount of blood being lost. So we've now done rest and elevate. We move on to the D phase of the action plan. The D standing for direct pressure. By applying direct pressure over the injury using a dressing, this will allow us to allow the blood to be soaked up. By applying pressure, will allow the blood to be slowed in the immediate vicinity from flowing out from the wound. Once we've applied the dressing, we then grab ourselves a bandage, and by applying the bandage over the top of the dressing, we can secure the dressing to the wound and allow the dressing to do its job. When we apply the bandage, we don't want to put too much pressure upon the wound, that way we may cut circulation off completely. But it needs to be firm enough so that we can slow the loss of blood. We secure the dressing using the bandage, and once we've done that, we slowly start to move our bandage up and down until we've completely covered the dressing and the wound site. Go all the way down and then past a little bit, past where we've finished the dressing, and then we keep using the bandage until we've used it all up. Sometimes you get clips with bandages. You need to be careful of these clips because they could tear your gloves, which in turn would allow you to come in contact with body fluid from the casualty. So clips, they are there, but there's no real reason that we need to use the clips, and we can just tuck any excess bandage into the last fold, and that should stay there. Once we've applied the bandage, we want to make sure we've not put it on too tight. A very simple test we can do is go past where we've finished bandaging, away from the heart, and just apply some pressure to the skin. In this case, I'll do it to the fingernail. The fingernail should go white. When I release it, it will return back to its normal color in about 2 seconds. This test is designed so that we can check for capillary refill. This will enable us to determine whether there is still adequate blood flow past where we've finished bandaging and that our bandage is not too tight. To sum up, the treatment of a bleeding injury. The color of blood is red. That stands for rest, elevate, direct pressure. Get our casualty to rest, elevate the injured part using a dressing and a bandage as best you can over the top of the wound. Once we're finished, get it elevated above the heart, get the casualty to relax, and if your common sense dictates to you that the wound is serious, you would then seek further medical advice.
My name's Dan Rogers and I'm a consultant gastroenterologist at University Hospitals of Leicester. Today we're going to spend about 5 minutes reviewing how to assess a patient with upper GI hemorrhage. After completing this podcast, you may be interested to view the rest of the series, through which you will cover the management of upper GI hemorrhage and the pathology behind its causes. Upper GI hemorrhage has significant morbidity and mortality associated with it, and the mortality rates have not altered in the past 20 years. They remain around 10% for patients admitted to hospital with upper GI bleeding and 25% for those who suffer a bleed while in hospital for another reason. Although it may therefore seem we've made little progress in the management of these patients, the age of patients presenting with this condition has increased, and so the patients presenting tend to be sicker and have more comorbidities, which may in part account for lack of progress at decreasing death rates. Upper GI bleeding is a common presentation, and most hospitals can expect to admit at least one patient a day. Although some causes of GI bleeding may be decreasing in frequency with greater awareness of the risk factors, it's likely that the incidence will continue to increase overall as the prevalence of liver disease continues to increase worldwide, and so it's important that all clinicians are competent to manage such patients. At this point, it is also useful to note that GI bleeding causes significant anxiety among clinicians of all grades, and hopefully after completing this series you will feel less anxious when assessing and managing these patients. On this slide you can see a patient with active bleeding from esophageal varices on the left and an arterial spurt from a Joulefoy's lesion on the right. After seeing these images you can understand why these patients can be so unwell. The most important assessment is to decide if the patient is actually bleeding. Hematemesis is the vomiting of fresh blood, whereas coffee ground vomiting may be altered blood but can also be due to a number of other causes, as most vomit will have some flecks of brown colour irrespective of the cause. Melena is the passage of dark, black, sticky, tarry stools and is suggestive of a more significant upper GI bleed. Hemachesia is red blood past per rectum and is normally caused by bleeding in the lower GI tract, but can occur if upper GI bleeding is particularly brisk. Hemachesia from upper GI bleeding tends to result in a hemodynamically unstable patient. This slide shows the endoscopic findings of patients who presented with upper GI bleeding during the UK National Upper GI Bleed Audit in 2007. Not all of these will be the cause of the bleed, but it's worth noting that ulcers were found in 36% of patients and varices in 11%. The incidence of varices had increased from 4% only 10 years previously, and it's likely to continue to increase. Whilst taking the history and examining your patient, it is important to make some inquiry as to the likely cause of the bleeding. Has your patient been taking NSAIDs, which may make you think about ulcer disease? Retching prior to the bleeding starting would make you think of a Mallory-Weiss tear, and a previous aortic aneurysm repair may make you think about aortoenteric fistula, which needs to be diagnosed with an urgent CT scan. If your patient is known to have liver disease, has risk factors for liver disease such as high alcohol intake, fatty liver disease or viral hepatitis, or clinical stigmata of portal hypertension on examination, you would be suspicious that varices may be causing the bleeding. Most of the tests on this slide will not come as a surprise, and so we will skip through them quickly. It is worth mentioning the renal function, as we're particularly looking for the level of urea, which is often raised out of proportion to the creatinine in a patient having an upper GI bleed, and also to remember to send blood for a group and save or cross-match depending on the severity of bleeding. It may also sound very obvious, but do remember to place at least one large IV cannula at the same time as taking your blood tests. You will undoubtedly have got a feel for how bad the bleed is whilst talking to the patient, and your examination findings will confirm or refute this. In particular, what is their blood pressure and pulse, and what is their capillary refill time. In the next 3 slides we will look at more formal ways of assessing the severity of bleeding that should help you decide if the patient needs a blood transfusion, and the urgency of any endoscopic investigations, together with the likelihood of the bleed being significantly severe enough to lead to the patient's death. This slide has been taken from the trauma literature and gives you an idea how much blood has been lost. We don't need to labour the points, but you can see that both systolic and diastolic blood pressure, together with pulse, respiratory rate and mental state, are all good markers as to the severity of bleeding. The Rockall score is useful at giving you a prediction of the likelihood of death being caused by this episode of GI bleeding. The score comes in 2 parts, a pre-endoscopy score and a post-endoscopy score. The pre-endoscopy score is very easy to calculate with bedside tests and history taking, and a score of 4 or above is associated with a high risk of death. Only the post-endoscopy score is fully validated, and again a score above 4 suggests a markedly increased risk of death. The score and the mortality rates associated with each score are available to download beneath this podcast window. You can see from this slide that the Blatchford score is more difficult to calculate as you require the results of blood tests as well as clinical parameters. However, it does have an advantage over the Rockall score as it predicts the need for intervention in the form of blood transfusion or endoscopy. A patient with a score of 0 should be safe to discharge home without inpatient endoscopy, and those with scores of 1 to 3 should be considered fairly low risk. Scores above 3 are associated with a much higher need for intervention, and these patients should certainly be kept in hospital for further assessment and management. It is, however, important to remember that neither of these scoring systems replace good clinical judgment, and if your gut instinct is to be concerned about the patient, you should go with this irrespective of the risk score. Again, the Blatchford score is available to download beneath this podcast window. The further podcasts in this series are below, and all other resources can be found on our Scoop-It page. Thank you for listening. This talk has been provided by the Leicester Gonda Collaborative Teaching Project.